Um, okay, well, good morning or good afternoon or evening from wherever you're joining, everybody. Um, Today, this is our, I think, fourth PACE meeting, which is the meeting for patient and caregiver engagement. So it's only for patients and caregivers that are allowed to participate in the meeting. And this is not to obtain, solicit, or share medical advice, but serve only for educational purposes. This event does not and cannot relate to care provided by kidney doctors. For individual health or kidney disease related questions, please speak with your doctor. With that, this is just the disclaimer in the beginning about what the content would be. So for a conference today, we're going to be talking about lupus nephritis. And then I'll initially start with a presentation. I'm hoping to stay within 15 to 20 minutes. And then after that, we can have more discussions, any questions. Again, the questions don't have to be related to lupus nephritis and could be anything, but any questions related to kidney diseases, if anyone would have. Okay, so like I said, I'll be talking about kidney lupus nephritis. Most of the content here is um, derived from KDIGO. It's an organization which is Kidney Disease Improving Global Outcomes. It gives guidelines to nephrologists to manage kidney diseases. Obviously, these guidelines are geared towards the nephrologist, so they're very technical. But my goal is to hopefully make them simple for patients and caregivers to understand. So most of the content comes from there. The guidelines that they make are based on a lot of clinical trials and the studies that are in this field, whichever we are talking about, like today about lupus nephritis. But there are also some expert opinions if there are not clinical trials and are by experts in that typical field, which we will be talking about. So starting with, before we actually talk about treatment outcomes, I'm going to start a little bit about lupus just because we need to know. So lupus is a disease, an autoimmune disease, which can affect any part of our body. Autoimmune meaning where your own immune system starts affecting your own body. And so you form antibodies. Antibodies are proteins that help us fight infections, but you start forming antibodies that start attacking any organ in your body or any part of your body. On this slide, as you can see, these are the most common organs that are involved in lupus. The skin being one of the most common ones, where you get to see this butterfly rash on the face. You could have involvement of the lungs, where you get fluid outside the lungs. You could have involvement of the heart and have heart problems. You could have involvement of the joints that can lead to joint pains, what we call as arthritis. There could be involvement of the blood vessels in the hands and fingers, where you get pain in your fingers and cold, called the Raynaud's. And obviously, today we are going to be focusing when you have lupus in your kidneys, which is called as lupus nephritis. So having inflammation in your kidneys due to lupus is what we call as lupus nephritis. Um, just a little bit of what happens in lupus nephritis. So this is our kidney, and in this kidney, and this is the outer part of the kidney, which is what we call as cortex. We have this is the working unit in a kidney, which is called as a nephron. All of us are born with 1 million nephron in each one of our kidneys. And that's all we get. So if they get injured due to any reason, then you lose them and you cannot make more later on after you're born. So you lose the kidney function and the filtering function of the kidney as well. In this nephron, this is that initial part of the nephron, which is what we call as glomerulus. And in lupus nephritis or any of the glomerular diseases is what we call it, is this glomerulus that gets affected. And this is a little bit more detailed version of this glomerulus. So a blood vessel goes in, it divides into a lot of what we call as capillaries, which are tiny, tiny, tiny blood vessels, where the actual filtration of the blood happens and the urine forms. and we call that as pre-urine, and then it goes into these what we call as tubules, and then gets processed and actually gets to be made final urine, which gets out of the kidneys into these ureters and into the bladder, which kind of comes here, as you can see. And so then the blood that's remaining, some of that's filtered out, gets out of this glomerulus as well. And a lot of inflammation, at least in lupus, what we're talking about today, happens in this glomerulus, but can also affect the tubules as well, but primarily in these glomeruli is where it happens. This is what we call, this is this cartoon version, just to understand it. And I know it's very technical here, but I'm not going to go into all technicalities, what I mentioned here, not that we need to know about them, but it helps, and the figure really helps to understand what's happening. So this is the cartoon of that glomerulus, and this is the blood vessels, and these are those tiny blood vessels, which are called as capillaries, where the filtration is actually happening. And as you can see, these yellow cells are actually just the cells which keep all of it together. And sometimes this inflammation happens, and that causes these blue cells kind of come in, or they get damaged. They also form the barrier, they get damaged. The outer layer of the glomerulus can get damaged, and because of the inflammatory cells that are coming in here. Most of the inflammation happens because of the blood vessels. This is that capillary. The white blood cells or the immune cells gets activated. They cause damage to these endothelial cells which are inside. They cause more white blood cells to come in and cause further damage and to the glomerulus, and the filtration affects the filtration in the kidney. So how do you diagnose lupus nephritis? Is by a kidney biopsy. So that's the only way that you can diagnose. You can suspect lupus nephritis if you have lupus and your blood and urine tests are abnormal, but the diagnosis is made by the kidney biopsy, which is, as seen in this picture, is done by this needle, where they take a small, your doctor is going to take out a very tiny piece of the kidney and then look under the microscope, usually done in the beginning, but sometimes it can be repeated as well to see the effect of the medicines that were given, or if there's still active lupus, or if it's better or not. The other test that your doctor might do would be blood test, which to assess how your kidneys are working. The major test that we talk about at that time is called a serum creatinine and sometimes a serum cystatin C. And with that, you calculate what we call as a glomerular filtration rate. It's an estimation, and it always comes below that creatinine. It's calculated by an equation that is used, and you plug in the numbers, your age, your gender, and your creatinine value, and you get a filtration rate, and that tells us how much the kidneys are filtering every minute of the blood. Obviously, it's an estimate, so it's not exactly calculated that you calculate from the how much the kidney, but it's a good estimate that helps us know how much your kidneys are working. And then the urine test help us know if there's actually inflammation in the kidney as well. So the two tests that are most useful in knowing is protein in the urine, and that can be done by two ways: either a spot that you give just one urine sample in a cup, and then you check a urine protein and creatinine, and you divide the both in what we call as a urine protein creatinine ratio. Or you can just collect all the urine for 24 hours and then give it to the lab, and you can get a 24-hour urine protein. And that's trying to estimate how much of urine protein is filtering out in the urine. In normal circumstances, if your kidney is working normally, there is no protein in the urine, or very, very minimal, but less than 0.2, but it can go really high if you have inflammation in the kidney and damage to the cells in the kidney. Your doctor might also do microscopy to look for blood cells in the urine, because that would be the other thing that might be present in the urine when your kidney has inflammation. And we look it under the microscope, and these tiny, tiny cells, as you can see, are the blood cells in the urine, these tiny ones, which are not normal. There should be no blood in the urine, because a normal kidney should not let the blood go into the urine. It should keep the blood cells in the blood and not let them pass in the urine. So that's kind of knowing about what lupus nephritis is, how do we track or diagnose it, and then coming to the treatment. These are the guidelines. Again, these are the basic guideline treatments for lupus nephritis, and then we'll come to a little bit more specific one. Most of them pertain to anybody who has any kidney disease, those who have protein in the urine with the kidney disease. They also pertain to anybody who has lupus nephritis because these are really important and affect how long your kidney works and keeping your kidneys as well as your body healthy. So if you do have protein in the urine, that protein in the urine leads to high blood pressure as well as swelling in the legs, what we call as edema. In clinical language. It's swelling in the legs. Sometimes that swelling can come into your belly, and sometimes it can come into your face, and your face can get bloated below your eyes, into your lungs when you have trouble breathing as well. So that's all sometimes primarily the effect of protein in the urine. And if the protein continues, that can cause further damage to actually the filtration function in the urine of the kidneys and affect the function of the kidney as well. So what helps decrease the protein in the urine? It's definitely a lifestyle modification by restricting your sodium, that's salt in your diet, doing a heart healthy diet, moderate protein restriction depending on how much protein is in the urine. And we had previous space kind of discussion about diet, which becomes really important in any type of kidney disease. Increasing your physical activity, smoking cessation. So if you smoke, it does increase the protein in the urine and causes a faster progression of kidney disease, so cessation of the smoking and reducing alcohol consumption. And then there's some medicines, and I'll go in a little bit on the medicines that decrease the protein in the urine, which also work as blood pressure medicines at the same time. So we kind of talked about lifestyle modifications. Again, I cannot reinforce enough about sodium restriction or salt restriction. Usually we would say about 2 grams of salt in a day, which is probably one of the most important things to help in decreasing that protein in the urine. Talking about edema, so if you do get a swelling in the legs, again, sodium restriction helps with the decreasing the swelling, but sometimes your doctor might put you on diuretics, which are water pills, and that's to help get rid of, again, that salt or sodium from your body, which your kidneys can't do by themselves, and so they need some help in getting rid of that excess of salt and water from your body, which is causing that edema. And then if you are on diuretics or water pills, then your doctor might check your blood work a little bit more frequently to monitor the electrolytes and the creatinine, because sometimes the diuretics or water pills can affect some of those electrolytes and creatinine as well. So specifically decreasing the protein, so we talked about the salt. It is really important to control your blood pressure really well, and aim for blood pressure less than 120/80, but the lower it gets, the lesser the protein in the urine. So lower the blood pressure somebody can tolerate without having symptoms of lightheaded, dizzy, fatigue, the better it is, because that would decrease the protein in the urine. The most important blood pressure medication that helps decrease the protein in the urine is a group of medications which we call as ACE inhibitors, or angiotensin convertase inhibitor, or ARBs. The most common in that group of medications is lisinopril or losartan. There are a lot of different medications with this in this group. Those end in pril or artan, and those are the medications that help decrease protein in the urine. They also decrease your blood pressure as well. And then there is a newer group of medications, which what we call as SGLT2 inhibitors. Again, this is a big name, but it is a group of medications that also decrease protein in the urine, does not affect your blood pressure so much, and they're go by the name of dapagliflozin or empagliflozin. Then we talked about smoking cessation and normalizing the weight to the ideal body weight if you are in the overweight or obese category. So some of the complications that happen due to protein in the urine, that your cholesterol may go high. That's just your body's response. When you are losing a lot of protein from your body, your liver tries to make a lot of protein to compensate, and it ends up making a lot of cholesterol as well. So your doctor will check your cholesterol level, and if they're high, would consider starting on a cholesterol lowering medicine, at least till they can fix your kidney disease and decrease the protein in the urine. Sometimes you might have a higher risk of blood clots because of that protein in the urine, and they might consider doing blood thinners if you develop a blood clot because of that. And then there's a lot of complications due to infections because you lose the protein. You also lose some of the antibodies. Those are also proteins that help you fight infections. So everyone who has significant protein in the urine, it is recommended to get a pneumococcal vaccine. All patients should get a flu vaccine every year and now COVID vaccine every year. And then shingles vaccination is primarily to prevent zoster if you're going to be on immunosuppressants, which is what we're going to talk about in a minute. And then your doctor might screen for some of the infections, which could be chronic infections, possibly to consider some of the medications that are needed because they can reactivate if you do have them, like tuberculosis, hepatitis B, C, or HIV, and syphilis in appropriate patients. So this is what the guidelines say in that big document about most of the thing. I kind of went over most of these, but I cannot reinforce that they are really important. I know we focus on the medications a lot, but this really keeps your kidneys healthy as well in making sure you're doing the right things to keep your kidneys working. So coming to now the immunosuppressive medications, or what we do to suppress or treat the lupus nephritis by decreasing that inflammation, which we talked about in the lupus that happens in the kidney. Again, I know there's a lot of technical terms here, but we don't need to go into details of these technical terms. But the reason I have these pictures here is when your doctor does your kidney biopsy, it goes to the pathologist, and the pathologist reads the biopsy and tells your kidney doctor that the different types of lupus nephritis there are. And in a simple way, as I can explain it, it means how severe the inflammation is in the kidney. And in the initial class 1 or 2, it's minimal inflammation is the way I would say. 3 and 4 are the worst inflammation. 5 is a very different type of lupus in the kidney. And 6 is when it's scarred and there's no more inflammation. And usually that would be the time that we would not give you immunosuppressive medications because now the kidney has scarred. So our goal is if I see somebody who has lupus, I would want them to not have 6. That's probably the worst one because now it's a scar and that's where we cannot do anything to improve the kidney function. The goal would be to have the minimum inflammation, but even if you have high inflammation, which is 3, 4, or 5, then there are medications to treat lupus in the kidney. So the first most important medication is what we call as hydroxychloroquine. It is an anti-malarial, so it is used to treat malaria in endemic areas, but it's been shown in lupus nephritis to work and decrease the inflammation and treat lupus nephritis as well. Hydroxychloroquine is that medication who somebody has lupus or lupus nephritis would be on it for a long, long time because it also prevents flares of lupus or lupus nephritis. Even when the disease is completely treated, it prevents it from coming back as well. So anyone who has minimal or mild inflammation, they would be on hydroxychloroquine, and then they would be on lisinopril or losartan to help that decrease the protein in the urine. They usually do not need more immunosuppressants other than hydroxychloroquine because the inflammation is minimal. And so you would start on hydroxychloroquine and lisinopril and losartan and then track your blood and your urine test and see that they improve with time. If they don't, then you might get rebiopsied or might consider adding another immunosuppressant after that. And then we'll talk about 3, 4, and 5, which kind of all are very similar, but a little bit differences, but for the most of the purposes, I'm going to keep them together. So if you have 3, 4, or 5, then you would need to be on hydroxychloroquine, lisinopril, and losartan. And then the third most common medication that your doctor would add would be glucocorticoids or steroids or prednisone, which could be oral. So it could be as pills or intravenous in the beginning and then convert them to oral. At least over the first 4 months of the diagnosis, you would be on certain dose of glucocorticoids or prednisone, starting with a higher dose, and then you taper over the time. Again, people who have been on steroids will tell that they have a lot of side effects. And so you cannot be on glucocorticoids or prednisone for a long time. And so what we say the next therapy that we add is something what we call a steroid sparing therapy, meaning that you need to add another immunosuppressant for you to be able to get off the steroids, which work really, really well in lupus, but alone they are not enough if you have lupus in the kidney, because they can't get rid of all the inflammation in the kidney and have a lot of side effects as well. So if one medication, if I had to remember, which sometimes I tell the medical students and I teach them, is if somebody has lupus nephritis, is mycophenolate. So mycophenolate is the major medication that works really, really, really well for the lupus nephritis. It is an oral medication, which has to be taken twice daily. You might start with a smaller dose and escalate up, usually about 2 to 3 pills in the morning and 2 to 3 pills in the evening of the mycophenolate. Its major side effects are mostly nausea, vomiting, and diarrhea. And then sometimes you might have a low white blood cell count, so your doctor would check probably your blood cells count a couple times frequently to make sure that they're not going low. It works in treating lupus nephritis as well as preventing flares, is what we call in lupus nephritis as well. Sometimes if it is, the inflammation is really, really severe, or if there is some contraindication that you cannot be on mycophenolate, then we do use an IV medication, which is called a cyclophosphamide, which is given IV. So you get an IV, you go to an infusion center, you get this medication, cyclophosphamide, every 2 to 4 weeks, and in different doses. Again, the side effects of that medication is nausea, vomiting, diarrhea, again, and can lead to low white blood cell count. So very similar side effect profile of both the medications. Cyclophosphamide is a chemotherapy medicine, which is also used to treat other cancers, but obviously much lower doses are used to treat lupus nephritis. And works equally well. So both these medications, mycophenolate and cyclophosphamide, have been studied head to head, and both work equally well in treating lupus nephritis. So your doctor could pick one or the other depending on how severe your lupus nephritis is. And then there are a couple of new medications recently that have been FDA approved for lupus nephritis. So it's been an exciting time for lupus nephritis with the newer medications that have been. One of them is called as belimumab, which is, or the trade name of what we call as Benlysta. It is an IV medication that is an add-on therapy for mycophenolate. So you have to be on mycophenolate 2 pills twice a day, so 2 in the morning, 2 in the evening, and then go for this infusion once every 4 weeks, essentially once a month that you go. Or there's a newer medication, what we call as voclosporin. It's in a class of drugs, what we call as calcineurin inhibitors. Again, it is an add-on therapy for mycophenolate, that you start with the mycophenolate 2 and 2, and then you take another more pills with it, which is the voclosporin. And there are studies that show that the combination therapy is sometimes better than doing mycophenolate alone, meaning in the study that showed that they had a group where they did mycophenolate alone and compared it to mycophenolate and belimumab, or mycophenolate and voclosporin, and they said that people went into remission, meaning that their lupus nephritis got treated better. More people got treated into remission, meaning more people in the group with the combination therapy went into remission or treated compared to the percentage of people in mycophenolate alone. So again, doing the combination therapy is better, at least in the studies we see. Obviously, it comes with more medications that you have to be on, so it might not be true for each and every person. So that's something that has to be discussed with your doctor, but at least we have a lot more options available for people with lupus nephritis. And then some of the blood tests, when you get started on these medicines, after a biopsy, they would monitor, like we said, was a complete blood cell count to make sure your white blood cells are not going too low. Your kidney function, that is serum creatinine primarily, and other electrolytes with it. Your urine test, which is looking for blood and protein in the urine to see how much inflammation is still there in the kidney. It's like what we call a poor man's biopsy, because you can't biopsy every time. So it it is an eye into the kidney to see if there's still inflammation. So your goal would have to be no protein in the urine and no blood in the urine. And when that happens, that's what we call that you're in remission, meaning that your lupus in the kidney is completely or lupus in the kidney is treated, or it's the inflammation in the kidney is gone when you have serum creatinine back to normal and there's no blood or protein in the urine anymore. And then your doctor might check lupus markers in the blood. So they might check your complement levels, which are C3 and C4, and some of the antibodies that are present, most commonly present in people with lupus, which are autoantibodies, meaning those antibodies that your body is forming against your own DNA. And that helps to know how severe or how active the lupus is in your body overall, not specifically in the kidney per se. So once you start those medications, usually those are done for about 6 to 9 months. And if your creatinine is back to normal or you're normal and there's no blood and protein, that's when we call that you're in remission and the lupus is treated, like I said. Once that happens, then you go into what we call as maintenance therapy, meaning that you want to prevent the lupus from coming back after that initial flare you had. And that's done for a total of about 3 years after the initial diagnosis. So a total therapy of 3 to 4 years is what is needed after one flare of lupus nephritis. And the goal is in this to prevent the second flare from happening once the initial flare is treated. And during this maintenance therapy, you are still on immunosuppressants. So people who have lupus nephritis still need immunosuppressions, but a little bit lower dose than what they were on in the beginning to treat, because now you're not treating the disease, you're just trying to prevent it from coming back into the kidney again. So you're trying to not let it flare up again. And most of the time, that's the most common medication used for maintenance is what we call as mycophenolate. Which, like I said in the beginning, that's the major medication to treat and then to prevent the flares again. So kind of just summarizing, if I would say when you have lupus nephritis, the most common medication is prednisone and mycophenolate. There are a couple of new medications and newer ones as well, which have a little bit better outcomes than doing just prednisone and mycophenolate. Either you go into complete remission where there's no protein and blood in the urine anymore and your serum creatinine is back to normal, and then you go into maintenance, or you get a little bit response, but there's some protein and blood still left in the urine, and so it's not completely gone, what we call as a partial response, or that initial therapy did not give you any response, what we call as no response. So these are the 3 things that could happen after that initial treatment is started. So if there is somebody who is into complete response, we talked about maintenance therapy. So they go into a lower dose of immunosuppressants again, which is MMF or mycophenolate. If you have partial or no response, at least this is the flow chart with the nephrologist follow, which the guidelines say. And the first one is making sure that there's enough adherence to the treatment, meaning it is not easy to take these many medications both morning and the evening. It has a lot of side effects and people don't feel well, then they have lupus. So one of the most important thing is to make sure that that people are adhering to the treatment that they've been prescribed. And the second is to make sure that to check the levels of the medications in the blood, because sometimes we assume that everybody would have metabolize the drugs in the same way, but sometimes people don't. And so your doctor might check your levels of the medications in the blood to make sure you have adequate blood levels of the medications in the blood to be effective. And sometimes they might do a repeat biopsy to make sure that it's not just scarred more. And sometimes just the scar will also lead to protein in the urine. So it's really hard to distinguish if it is scar of inflammation. Like I said, we use that as a surrogate or for inflammation, but sometimes it's not all the time correct with that. So might consider doing a biopsy, or if it is a different diagnosis or it has switched to a different diagnosis. And then the fourth one, if we've done all this and there's still active inflammation in the kidney, would be switching to another alternative treatment, which would be a combination therapy or other infusion medicines. The most commonly used is rituximab, which is another infusion medicine, not cyclophosphamide, which we talked about before, but also a chemotherapy, again, much lower doses used than used for treating cancer, but effective in lupus nephritis, again, as an add-on to mycophenolate. Like I said, mycophenolate goes in the baseline for everybody, and then you can add rituximab or other infusion medicines, newer ones which are coming up, which comes to the enrollment in clinical trials. So if you're not responding to that, then your nephrologist might consider you enrolling in a clinical trial because there are, like I said, it's an exciting time for lupus nephritis with a lot of newer medications in the pipeline. The two recently FDA approved, and the third one hopefully soon to be FDA approved, which works very similar to rituximab as well. So thinking about clinical trials, so which clinical trials to look? So in our GlomCon, the PACE where we are, our website also has the clinical trials which are currently enrolling based on their disease type. And if you can look, there's the lupus nephritis, and if you click there, then it would come up all the clinical trials that are enrolling and the enrolling sites as well, which would be the closest to you. So if somebody is not responding to the initial therapy or are resistant and are in partial remission, it would be totally okay to go to your kidney doctor to see that would I be eligible for enrolling in a clinical trial to get newer medications if you're not responding initially. The other way to look at the clinical trials is by going on this NIH website, clinicaltrial.gov. And as you can see, you can type in the condition or the disease, and you can type it lupus nephritis. You can do all studies or recruiting or not yet recruiting studies. And then when you search, it will give you a whole list of all the studies. So all clinical trials have to be registered with the US government. And so all the trials would come up here, which are recruiting for lupus nephritis if you had to look at with the locations where they would be as well, which you can filter by the location as well with your address or your city or your state as well. So it would be, if you would want to look the trials for your disease, that would be one way to go as well. And then the other resource would be our GlomCon PACE web page, where we have resources to learn more about the diseases based on disease type. And you can look up at lupus nephritis handout here as well, which gives you a little bit more detail and kind of learn about the disease at your own pace there as well. So just to take the take-home points, you do need a kidney biopsy to diagnose lupus nephritis. The two common medications that are used to treat lupus nephritis are prednisone with mycophenolate, but there are a lot of newer FDA-approved medications now available for lupus nephritis. The two most common that are recently approved are belimumab or Benlysta and voclosporin. And then clinical trials are important to advance the field of in any science, but like today we're talking about lupus nephritis and find new therapies for treatment to have options available for you and for other people with the same disease in future to have better outcomes and to keep the kidneys working. And I think that's my email address. If anybody has questions, again, I can obviously advise that clinical treatment would still be recommended based on the doctor you're seeing, because I cannot offer treatment advice based on this, based on the emails. And that is all I had for today.